Here's our progression for today. 1. The neck. 2. The larynx. 3. Oral cavity and salivary glands. 4. Ear pathology and vertigo. And finally, 5. The nose and paranasal sinuses. Let's get to it.
Section 1. The neck, anatomy, and pathology.
Think of the cervical fascia as anatomical highways. They literally dictate how deep neck infections and hemorrhages spread. You've got the superficial, pretracheal, and prevertebral layers creating these distinct compartments. So when you're evaluating a rapidly expanding neck mass, knowing these boundaries tells you exactly where a fluid collection or infection is going to track, especially if it's heading downward into the mediastinum, which is obviously a massive deal.
Now you absolutely have to master these 6 lymphatic node levels because they directly dictate your surgical margins during a neck dissection for metastatic disease. Levels 1 through 6 map out the submental, submandibular, jugular, posterior triangle, and central compartments. Squamous cell carcinomas of the aerodigestive tract spread in highly predictable patterns right through these specific levels. Basically, your understanding of this map determines whether you're performing a radical, modified radical, or just a selective neck dissection.
Shifting to critical pathology, Ludwig angina is a must-know. This is a severe deep space cellulitis of the submandibular and submental spaces. You need to recognize it immediately. Why? Because the resulting bilateral swelling pushes the tongue upward and backward, and that can rapidly and fatally occlude your patient's airway.
Okay, so the biggest branching point when evaluating a neck mass is the patient's age. If it's an adult, you presume it's malignant, most commonly metastatic squamous cell carcinoma from a primary tumor in the oral cavity, pharynx, or larynx until proven otherwise. Pediatric masses? Totally different story. They're typically inflammatory or congenital. A classic pediatric example is a midline thyroglossal duct cyst. You know, the one that famously moves when the child protrudes their tongue? That one requires the cystrunk procedure for definitive removal.
Because neoplasms are so rare in kids, the pediatric workup leans heavily on safe, non-invasive ultrasound rather than CT scans. You're mostly just trying to differentiate congenital from acquired masses here. We really only reserve CT imaging for assessing things like complex, deep neck space infections. So, observation, antibiotics, and ultrasound-guided diagnoses, that's what drives this clinical pathway.
In stark contrast, the adult protocol is aggressive. Assuming malignancy, you've got to escalate quickly to head and neck CT scans and ultrasound-guided fine needle aspiration. Note, never do an open biopsy first because you absolutely do not want to seed a tumor tract. You'll also often need operative panendoscopy. This lets you visualize the entire aerodigestive tract and take biopsies to hunt down whatever unknown primary tumor is actually fueling that metastatic cervical node.
Section 2. Laryngeal disorders and trauma.
All right, the larynx is split into 3 key parts: the supraglottis, the glottis, which holds your true vocal cords, and the subglottis, extending down to the cricoid cartilage. Now, this isn't just trivia. This exact anatomy dictates both the presentation of congenital pathologies like laryngomalacia and the specific staging and surgical treatment for laryngeal cancers.
When you're dealing with pediatric airway emergencies, you have to instantly distinguish between these 2 conditions. First, viral croup. It presents with that classic barking cough and a radiographic steeple sign from subglottic edema, and we usually manage it with humidified air, steroids, or racemic epi. Contrast that directly with life-threatening epiglottitis. Historically caused by H. flu type B, these kids look toxic. They're drooling, leaning forward, and it demands urgent airway management in the OR along with IV antibiotics.
Here's a vital surgical pearl for the central neck. The recurrent laryngeal nerve, a branch of cranial nerve 10, provides motor innervation to almost all intrinsic laryngeal muscles. So if you nick one nerve during a thyroidectomy, your patient gets unilateral vocal cord paralysis, meaning hoarseness and aspiration risk. But if you injure both recurrent laryngeal nerves, the vocal cords just rest right in the midline. That creates a devastating airway compromise that's going to require an emergency tracheostomy.
Section 3. Oral cavity and salivary glands.
Let's talk Pierre-Robin sequence. It's defined by a classic triad: micrognathia, glossoptosis, which is basically a tongue that falls back, and a U-shaped cleft palate. Because of this exact anatomic sequence, these infants struggle with severe airway and feeding issues. They're frequently going to need specialized prone positioning, a glossopexy to pull the tongue forward, or even a tracheostomy just to overcome that physical obstruction.
When you're evaluating salivary neoplasms, there's a golden rule you got to remember. The smaller the salivary gland, the higher the likelihood of malignancy. Most of these tumors pop up in the large parotid gland, and 70% of those are benign, usually a pleomorphic adenoma. But if you find a tumor in the much smaller sublingual gland, it's highly likely to be malignant, like a mucoepidermoid carcinoma. Oh, and keep in mind any parotid gland excision puts the facial nerve, cranial nerve 7, at significant risk, so meticulous intraoperative nerve monitoring is an absolute must.
Section 4. Ear pathology and vertigo.
It is so essential to classify hearing loss correctly right out of the gate. Conductive hearing loss stems from a physical blockage or mechanical failure in the external canal or middle ear. Think otitis media, cerumen impaction, or ossicle issues. Sensory neural hearing loss involves the inner ear structures, specifically the cochlea or the cranial nervate neural pathway. Fun fact, congenital sensory neural hearing loss occurs in about 1 in 1,000 newborns, and roughly half of those cases are genetic.
Let's tackle dizziness. Time is literally your best diagnostic tool for true inner ear vertigo, which patients will describe to you as this distinct room-spinning sensation. If the vertigo lasts only seconds to minutes and head movement triggers it, that strongly points to BPV. If attacks last minutes to hours and come with tinnitus and hearing loss, you're looking at Meniere's disease. And if the severe vertigo is continuous for hours to days, that indicates vestibular neuritis or labyrinthitis.
So by pairing the exact duration of the vertigo, seconds, hours, or days, with associated auditory symptoms like earfulness or finding loud noises painfully amplified, you can systematically arrive at the correct diagnosis. From there, you proceed directly to targeted treatments, whether that's positional maneuvers for BPPV or dietary changes for Meniere's.
Section 5. The nose and paranasal sinuses.
Acute rhinosinusitis is incredibly common, and the crucial distinction here is viral versus bacterial. Most cases are purely viral. They just need supportive care, like saline irrigations. But when a bacterial superinfection hits, classically from strep pneumococci or H. flu, your first-line treatment is amoxicillin. Now, the huge takeaway here is avoiding the classic pitfall of rhinitis medicamentosa. This is a severe rebound nasal congestion caused by patients overusing over-the-counter topical decongestants, like oxymetazoline, for more than 3 days in a row. It's a highly testable side effect, and you've got to counsel your patients on it.
As we wrap up this explainer, I want to leave you with this. How will having these specific algorithms down cold shift your confidence the next time you face a complex neck mass or a critical airway? Mastering this anatomy, from the cervical fascial planes to the exact path of the recurrent laryngeal nerve, isn't just about passing your exams. It's about fundamentally transforming your situational awareness and your decision-making speed in the OR and the emergency department. Keep reviewing these pathways, lock them in your mind, and you'll be ready for absolutely whatever walks through the door.